You're listening to In the Thick of It, a podcast from the HCM Society, where we interview experts in the hypertrophic cardiomyopathy field to broaden the awareness of new HCM studies and advancements.
Please enjoy today's discussion supported by an unrestricted educational grant from Cytokinetics.
On today's episode, Dr. Benjamin Van Boxtel welcomes Dr. Daniel Swistel and Dr. Joseph Dearani for a conversation on septal myectomy and mitral valve repair. What exactly is the importance of individualized patient care when treating hypertrophic cardiomyopathy? Join these experts as they break down the necessity of tailored procedures, multidisciplinary collaboration, continuous learning, and adapting to evolving technology within the field. Dr. Swistel and Dr. Dearani also delve into the importance of thorough evaluations and collaboration among specialists when treating HCM. But what challenges do they face in their multidisciplinary teamwork? Learn more about their methods and how advancements in surgical techniques are revolutionizing treatment options for HCM and more. Let's get in the thick of it. Here's Dr. Benjamin Van Boxtel, Dr. Daniel Swistel, and Dr. Joseph Dearani.
Hello, everybody. I'm Dr. Ben Van Boxtel. I'm a cardiac surgeon in Morristown, New Jersey, and I'm joined today by Dr. Dan Swistel from NYU and Dr. Joe Dearani from Mayo Clinic, two surgeons that I've idolized for quite some time, very important figures in my field. Guys, if you could just sort of briefly talk about your experience with surgical approaches for HCM and how long you've been doing it and number of procedures you performed, et cetera.
Well, I can start with that. I and my medical colleagues started the HCM program in New York City about almost 30 years ago now, when HCM surgery was sort of just becoming slightly more visible globally, probably secondary. And Joe, you could comment on this. I think a big change occurred when 2D echocardiography was developed. And that kind of dramatically changed how we see HCM and spawned a lot of advances in both medical and surgical therapies. So my medical colleagues and I have run an HCM program in New York, now at NYU for all those years. And we've probably operated on just shy of 1,000 patients. And we see roughly 3,000 or 4,000 patients in our clinic over the years.
So yeah, that's I would agree with that, and I think that the interest in myectomy surgery actually really came into the spotlight in the mid-1990s when the HCMA, the Hypertrophic Cardiomyopathy Association with Lisa Sahlberg, became very prominent because it essentially increased awareness. And so as a result of the increased awareness, the option of surgery became much more evident, particularly since medical therapy was really consisted of beta blockers and calcium channel blockers and maybe back at that time disopyramide. So there was the medical therapies were somewhat limited, and either patients had persistent symptoms despite medical therapy or they had side effects from the medical therapy, which pushed them over into a surgical category. So, now at Mayo, I have been very blessed to have had a couple of senior mentors, Dr. Danielson, who was really practicing at a time when myectomy surgery came to be, soon after Dr. Morrow introduced it. And then my senior colleague, Dr. Hartzell Schaff, really the two of them taught me most of what I know. The myectomy practice at Mayo now in Rochester is obviously over the course of many, many decades now is in the 5,000 plus range. And we have a really a fully fledged, multidisciplinary team that goes beyond cardiology and surgery. It includes genetics, it includes electrophysiology, it includes more of the complicated imaging strategies, and that's really what you need in the current era, because the treatment strategy needs to be matched with the patient problem, and there are some differences between the patient preferences. What medical therapies are available. There's new medical therapies on the market now that I'm sure we'll talk about. Alcohol ablation. There's just nuances with everything, and So having a multidisciplinary team where a patient has a chance to interact with all of the basic stake, holders, I think is really what's necessary so that people get channeled in the right direction. And that's what a center of excellence, consists of today.
Yeah, both great responses. And, as a, I guess, junior cardiac surgeon who's performing quite a bit of myectomies, our program is on the newer side. We had a very well established medical HCM program, but not really a dedicated surgeon. And advice that I'm gathering from this conversation, exactly sort of what we're doing is putting all the building blocks together. So electrophysiology, like you said, genetics is a big one. And as you mentioned, it's a team sport. So getting every single member of the team lined up to really have a comprehensive myectomy center is very important. When you started out, if you were in my position starting up this program, what advice would you give to someone who is in there? We're in our fourth or fifth year of really doing routine myectomies. What's some advice you'd give me?
Well, I think the biggest thing that and you touched on this briefly, Joe, the biggest change since the advent of myectomy surgery, and we can backtrack a little bit. I mean, myectomy surgery is one of the very earliest of all open heart procedures that were developed in the 1950s. First in England, and then really the opening of the era was from the NIH and Andrew Morrow. What's changed since then, and as you alluded to briefly, in the 1990s, and the advent of two-dimensional echocardiography, is just that all of these patients are a little bit different, and everybody needs a specifically tailor-made procedure in order to maximize, the success of the result. So, the pathophysiology is no longer just a thickened septum. The pathophysiology includes accessory internal left ventricular structures, different morphologies to the leaflets of the mitral valve, different morphologies to the septal thickness. And so all of these things, need to be very carefully, I think, elucidated before surgery even starts. And I think in this day and age, that's the key to starting a program and appreciating all of these nuances so that they can be understood and dealt with adequately during the actual operation.
Yeah, I would, just to expand on that, I absolutely agree with that. I would say on the cardiology side, I think the cardiologist, needs to be well versed with all of the medical therapies and needs to be well versed with the interpretation of imaging, because imaging today is really, I think, the differentiator for the surgeon. I mean, the imaging now is so good that you can, I mean, if you wanted to, you could actually do the operation on a particular patient in your office with a model if there was, some unusual situation where you really wanted to work on it before going to the OR. So imaging basically tees it up for the surgeon, but the cardiologist really needs to know what to look for. And as Dr. Swistel was saying, it's more than just the septal thickness. It's the function of the mitral valve. Is there a structural problem with the mitral valve, or is it just SAM-mediated mitral regurgitation? How thick is the septum? Is there gadolinium enhancement on an MRI examination? And if so, how much? Should an EP consult be obtained, because of some history of questionable of ventricular arrhythmias and so on and so forth? So the cardiologist needs to be aware of all that. And I do think it's important for a cardiologist to be in the operating room doing the TEEs, particularly early on in their experience and in your experience, because it really showcases what the possibilities are, what the limitations are, and what a surgeon can and can't do. And so a cardiologist that's present in the OR and is looking at the TEE images, which invariably may add a little bit more than a transthoracic image, and what to look for at the mitral valve. I mean, this is what you want to know before you scrub in. From a surgeon's standpoint, I would say that a surgeon first needs to have a very good understanding of the interior architecture of the heart. Where is the ventricular septum? When does it go from the septum to the free wall? Where's the conduction tissue? Mitral valve issues, aortic valve issues. How far down does the obstruction go into the depth of the ventricle? Is it mid? Is it basal, etc.? And the surgeon needs to have a command of mitral valve surgery, aortic valve surgery, and of course septal myectomy surgery. And so, because all of these things you're going to encounter with many patients, and so just knowing how to do a septal myectomy but not knowing how to do a mitral valve repair is not a good situation. So, like you did, Ben, I remember when you came and visited Rochester, and I think, surgeons always learn new things by going and visiting surgeons. And, it may be, I still learn a lot of things when I go visit surgeons. It may be something very simple that I never thought of, or it may be something like, wow, that's a great way to approach it or expose it or to do it. So you got to go visit, you got to take notes, but at the end of the day, you want to have a steady volume of patients. As a surgeon, if you can do, 2 or 3 of these a month so you feel like you're seeing it over and over again, that makes sense. If you're going to do a myectomy once or twice a year, that's no help to anybody. It's not good for the patients. It's not good for the surgeons. Everybody's uneasy. So you got to have a steady volume so you feel like you're maintaining your skill sets, you're getting exposed to enough anatomic variability that you're not afraid of the curveballs anymore. You're kind of like, oh, yeah, we've seen that before. I know what I'm going to do there. And then periodically, even during the middle part of your career, do not hesitate to go visit and see what else you can pick up. I'll close by saying that we had the Chinese surgeons that came and here last week, and they talked about their transapical beating heart myectomy device, which when I first heard about it, I was skeptical. After seeing and hearing their presentation, I am totally sold on it. I think it's a better way to do it than the way that we're doing it right now. And I think that is the that is going to be the way of the future until catheter-based, myectomy instruments become, available, which is probably not far down the road either. But you must evolve with the technology, and that's how we stay current and we stay credible.
Let me just expand a little bit on what you said earlier, Joe, in terms of evaluating the patient before and during surgery. At NYU, I go over the patient's anatomy with the cardiologist before the case even starts, usually by evaluating the patient's pre-op study, which almost always consists of an MRI and a transthoracic echo. And then once we're in the operating room and a TEE is in place, then we go over the echo again with the cardiologist and our cardiac anesthesiologists, who are well versed in this procedure as well. And we evaluate the difference in the nuances between the TTE, the TEE, and then of course three-dimensional echocardiography has become very useful for us as well. So all of those modalities we discuss together before we even begin the actual operation. And I think that's key to success.
Well, that's great to hear that feedback. That's precisely what we did when we first started doing myectomies routinely at my institution, was made sure we had enough volume that it wasn't a once in a while operation. And then I have my cardiology colleague and partner in the operating room every single case doing a TE, in addition to the images that we have, obtained and reviewed, firsthand. I, explained to some of my colleagues, I think that the myectomy operation is very much unlike other cardiac surgical operations we do, which are various forms of plumbing, in many ways, whereas the myectomy is, I always describe as like plastic surgery on the interior of the heart. But if you, go a little too deep or you don't go deep enough, the consequences are very, very high. So having that real-time feedback with the TE is I can't imagine doing that without. And we're also not afraid to reclamp and take a little bit more, if things look a little different on the, post pump echo than they did, to the naked eye. So I think that's, having that real-time feedback and the chance to really make sure everything looks perfect before you leave the operating room is something you may not be able to get with someone who's not very, very well versed in imaging that part of the heart.
Well, this is interesting because, I don't know, Joe, you can comment on this as well. We almost always find the septal thickness a little bit thicker on the intraoperative TEE than we do on the preoperative TTE. And I think that has a lot to do with changes in dynamics and unloading of the patient after cardiac anesthesia. And because, my other comment would be that probably 20 or 25 years ago, we saw way more patients with septal thickness above 2.2, 2.5, 2.8, closer to 3 on rare occasion. And in this day and age, I rarely have a patient with a septal thickness above 2 or 2.2 centimeters. And I think because these septums tend to be a lot thinner than they were years ago, and there's a whole reason why we can hypothesize why that's true as well. But, every millimeter can make a big difference. And so the evaluation of the differences in septal thickness from pre-op to pre-myectomy, intra-op, I think can make a big difference.
I think the other thing we haven't talked about, but I think also plays into success, is having a protocol in the OR where, you do the TEE, you do your measurements. And then, before you go on, you measure pressures, you do provocative maneuvers if necessary. And then, after you come off bypass, you repeat all these maneuvers because the conditions of anesthesia always make everything look better in the operating room. The gradient's never as high, and the degree of MR is never as much, and so it's easy to be fooled in the operating room to thinking that you did a good job, and then they get their discharge echo and they still have a gradient, and you're kind of like, well, they didn't have it in the operating room. So you do need to be very intentional in the operating room about trying to make sure that you really showcase the gradient, and you actually do maneuvers that are going to really bring the gradient on. So when I come off bypass, I want them to be a little hypovolemic. I want them to be a little tachycardic because I want things to look not good, under those circumstances, as opposed to making their heart rate 60 and, jacking them up with a whole bunch of volume. And then, because that's not the way they're going to live when they get out of the hospital. So I think, adhering to whatever your protocol is in the OR is also very important, so that you can reproduce the quality of your operation in a sensible manner. It's not a free for all every time you do this, doing it differently every time.
Right, and that's you mentioned how when surgeons travel to other facilities, you may pick up something big, you may pick up something small. And my last visit to Mayo, I mean, we were pretty much doing things probably pretty similar to the Mayo way, because where I trained at Columbia, the surgeon there was trained by Hartzell Schaff, so there's a lot of similarities there. But
Yeah.
we weren't doing the direct LV chamber pressure measurement with the spinal needles, and that we started doing that, and oftentimes it syncs up with what the echo shows you, but it's just an extra little piece of information. So little things like that you pick up along the way really helps, I guess, hone the craft.
As a congenital surgeon, we measure needles. We put needles everywhere, RVs and PAs, because as I tell the residents, needles do not lie. Echo, a lot of the determinants by echo are all, they're qualitative. There's a little bit of subjectivity, how they're holding the probe, what's the Nyquist scale at, but needles tell the truth. And so it's a very good habit to get into, whether it's that aortic valve replacement. I mean, the threshold to measure, gradients should be low, particularly if there's any concern or what you're seeing on the monitor is not jiving with what they're seeing on the echo. I mean, get the needles out and measure, because generally speaking, the needles don't lie.
So for those of you who are joining us who are not familiar with the surgery, we're describing the septal myectomy procedure, which is the most, I guess, mechanical way to fix a mechanical problem when you have septal hypertrophy that causes LVOT obstruction and SAM. So other treatment modalities we know about, especially cardiac myosin inhibitors, septal alcohol ablation was mentioned. Would you both mind walking me through your patient selection sort of algorithm in your mind? I mean, obviously I guess what makes a great surgical candidate in your mind, and what makes someone you don't want to operate on, aside from the obvious things like maybe a very frail or elderly person, or I guess what are some things that you look for in your pre-op evaluation of these patients?
Well, as I mentioned a little bit earlier, the pathophysiology of obstruction has certainly evolved over the course of my HCM career over the last 25, 30 odd years. And so whereas in the past you might have been a little hesitant to try to manipulate an interventricular septum, which is in some patients actually normal in thickness, but the patient still has outflow tract obstruction for a variety of other structural abnormalities and varying pathophysiology. I think in this day and age, we have a whole series of other tricks that are at our surgical disposal that allows us to intervene on these patients. I think something that's not often discussed, but I feel like a lot of patients who might otherwise be shuttled towards medical management, and then they fail medical management, or they choose not to have medical management, but let's say they fail medical management. I think that the negative inotropes, the drugs like beta blockers, calcium channel blockers, disopyramide, and now the myosin inhibitors, they work very, very well on patients that have relatively thick septums. And I'd be curious as to your take on this, Joe. But my sense is that patients who don't have a lot of septal hypertrophy don't respond to negative inotropy because they have more of a structural abnormality inside their ventricular chamber. And I find that those are the patients that are coming for surgery, certainly in my practice, more often. And that's maybe the other reason why I don't see a lot of patients with septums that are so thick in this day and age.
Yeah, I agree with that. For me, Ben, I want to see a gradient. If a cardiologist calls me and tells me that they have a hypertrophy and they have a gradient, that means surgery to me. I mean, a gradient, as we know in cardiac surgery, obstructive lesions, regardless of what they are, mitral stenosis, aortic stenosis, pulmonary stenosis, RVOT obstruction, LVOT obstruction, they respond incredibly well to surgery. As you alluded to, it is a structural problem. And when you fix the structural problem, they feel better. And in fact, they live longer. And so I like to have patients on medical therapy before offering them surgery. I mean, that's sort of a typical step. I mean, I would never advocate for surgery in a newly diagnosed hypertrophy that's never been on medical therapy. I would give them a trial of medical therapy for 3 months, or let the cardiologist, work with some medical therapy and see whether symptoms persist and how they feel. And if they don't feel well and are, they still have symptoms, or they have side effects from, the beta blockers, and they just want to get off medicines, then surgery is in the cards for me. So for me, and we're not going to talk about non-obstructive hypertrophic cardiomyopathy. That's another discussion. But for obstructive hypertrophic cardiomyopathy, I want to see a gradient. With or without MR, I want to see a gradient. If they have MR, then I want to know the mechanism of the MR. Is it SAM mediated? Is it structural? Is it prolapse? What is the reason for the MR? And those are patients that do really well with surgery. I mean, if they have severe obstruction or they have a structural problem with the mitral valve, surgery is the answer, and it works really well. Symptomatic improvement is essentially almost immediate. I mean, these patients feel better walking around the hospital with a hemoglobin at 9 and 2 chest tubes still in place. They feel better like that than they did before they walked into the hospital. So 3 months later, you can imagine how they feel. So that's, I think, what I'm looking for. And I think that when their symptoms don't exactly fit with the echo, I mean, their symptoms to a cardiologist sound like obstruction. It's exertional. They walk up the stairs, they squat, they have a big meal, whatever it is, and they don't feel well. And a regular transthoracic echo doesn't really elicit a gradient. Then you have to start doing exercise echoes. You have to do things to try to simulate what happens when they're exerting themselves. And sometimes it ends up being a provocative cardiac catheterization. But don't a cardiologist really has to exhaust all these maneuvers, particularly if their symptomatology does not match the echo, because a lot of patients have this latent obstruction. They get a gradient of 10 to 15, 20 millimeters of mercury at rest. Maybe there's chordal SAM, but not much beyond that. But they give a classic history for obstruction. Then you got to put them on a treadmill. You got to do an exercise echo, or you got to do something, particularly if the anatomy looks like they should be obstructive. If the anatomy looks like they should be obstructive, then you got to look for it. And a good cardiologist, back to what we were saying in the beginning, they know how to do those things. That's really what I'm looking for. Mavacamten, I actually think that for I see a lot of patients now with pretty thick septums and mid-ventricular obstruction, because I think that there's a limitation with medical therapy. There certainly is not a great role for alcohol ablation when, they have septums that, get to be quite thick, or the obstruction goes to the mid ventricle. I mean, that doesn't work that well. But I think, mavacamten is being handed out like candy right now. I mean, it's despite its expense and despite this exhaustive surveillance protocol, which I'm surprised that patients are enthusiastic to sign on to that, with the intensity of what needs to be monitored forever. I think that we're going to see more patients with thicker septums, because I think that they're going to fail medical therapy and then it's going to come back to surgery. That would be my prediction. But and one thing that Dr. Schaff always mentions, which I think is an important thing for cardiologists and patients to hear, is that there is no medical therapy that causes a reduction in hypertrophy. And we know hypertrophy is bad in the long term. Elevated LV mass index is not good. So that's one thing that surgery does. We reduce LV mass index, and over time the LV mass index will continue to come down once you get rid of the gradient. So medical therapy doesn't do that. And we know that after surgery, the late survival is the same as an age-matched population. And that kind of gets lost in a lot of discussions with various, practitioners and so on and so forth. And so when that's messaged to a 40-year-old, that's becomes much more of an appealing alternative than chronic medical therapy, where you never actually normalize the survival curve and you're still tied to the medicines indefinitely. So I don't know, Dan, if you've experienced the same thing, or Ben yourself, but that's an important little nuance, is that medical therapy, it may improve symptoms, but it does not cause a reduction in hypertrophy.
Well, that's exactly true, and I think that's an excellent point, Joe. And I would just expand by saying that when I talk to patients who are referred for surgical myectomy therapy, I often look at it this way in front of them. I said, listen, if you're 25 years old or 26 years old, this is never going to go away for you. You will be on mavacamten or this other medical management forever. And when you're 26 and you're looking at 50 years of medical management, does that really make sense for you? And I have a different discussion with individuals who are in their 60s. And I said, well, if you're on mavacamten and it works for you for 2 years, 3 years, we don't know what will happen in 5, 7, or 10 years. And now you're going to be 70 years old. And do you really want to have septal reduction surgical therapy when you're 70? You'd be much better off having that procedure and mass reduction when you're 58 or 60 or 62 than when you're 72 years old. So, you can hedge your bets somewhere in between there, but I think for the very relatively young patient and for the older patient, I think surgical septal reduction therapy is really makes a lot more sense. Of course, I'm biased, but I think a lot of what you've said, Joe, in terms of life prognosis plays a big role in the decision making for certainly those two groups of patients.
I think it's important for the patients to remember as well. I mean, obviously, mavacamten shouldn't be handed out in the, community cardiology practice that is seeing one, hypertrophic patient a year. The centers that do a lot and see a lot, like the clinics we all work with, thousands of medical patients. I've almost seen not a reduction in the number of surgical patients, but an increase because more people are sending patients in for mavacamten candidacy and finding to be better, surgical targets or surgical patients for whatever, reason. And I oftentimes have that conversation with my patients as well. I describe what's going on. I draw the extra muscle. I show how the blood's not getting out of the heart and it's pulling the mitral valve over. And I say, now we can do open heart surgery, which sounds very scary, but it's going to go take that piece out and make your heart not normal, but more normal and functioning a lot more normal. Or we can just turn the heart squeeze down everywhere and see if you feel better. I mean, most young patients who we tell them the risks of surgery are very low, the success rate is very high. I mean, most of them, I think once they conceptualize that, they realize this is a structural problem that needs a structural solution. So it's a great tool, no doubt. But I think it's, from my perspective, it's a good adjunctive, tool, or for patients that just can't have surgery for whatever reason. So speaking of provocative maneuvers, I have a question that I know is a little bit provocative in our fairly small field of surgeons that perform surgical myectomies routinely. I learned, again, sort of in the Hartzell-Schaff lineage that, the anterior leaflet of the mitral valve is almost never needed to be touched. It's about how deep, when I say deep, I don't mean the thickness of the septal resection, but the depth down toward the apex that you go. It's all about the depth of the resection that is going to get rid of the SAM, and that I know that he seldom touches the anterior leaflet of the mitral valve. Can you both tell me your thoughts on concomitant plication of the anterior leaflet of the mitral valve and how routinely you do that?
Well, yeah, I'm a little well known for specifically manipulating the anterior leaflet of the mitral valve, so I guess I can comment. And again, I go back to something I commented to a little earlier, that I see more and more patients without septal thickness at all. And I don't know whether that's a difference in referral pattern or a more aggressive pharmacologic management from those who refer patients to me. So I can't speak on that aspect of this issue. But certainly more and more of my patients have septums that are really normal, maybe 1.5 centimeters. Having a septum that's 2 centimeters is a good day for me. I seldom see that in this day and age. So in return, I've turned to manipulating the anterior leaflet of the mitral valve. Now, do I do that on everybody? I think I do it on the last study that we did quite recently. It's about 40% of the patients have some sort of manipulation of their anterior leaflet. Now, that could be something as simple as cutting secondary cords, or it could be something as aggressive as a plication, or something where we resect the leading edge of the anterior leaflet. That's called a residual leaflet resection. But I think it's an adjunctive therapy, and it has shown to be quite effective in the long-term follow-up in resolution of the symptoms and outflow tract gradients.
I'm more of a disciple of Dr. Schaff, so I, rarely do something to the mitral valve in the absence of a structural defect. I will say that when I do fuss with the anterior leaflet, it's when the tip of A2 has gotten to be very floppy and redundant. And, you see it on the echo, you see it almost looks like a little cord. The tip of A2 can get from chronic SAM, can get very redundant. And so when I see that, I definitely plicate that, but it's just the tip of A2 just to eliminate that little floppiness. In terms of doing something in the body of the anterior leaflet, I've not done it. Now, to Dr. Swistel's credit, I mean, Dr. Schaff always talks about making sure that the trough gets down beyond the leaflet and opposite the papillary muscles. And I think that if you don't get your myectomy down that far, then you just move the point of obstruction a little further in the ventricle. So by shortening the leaflet, you compensate for that. So I don't think it's right or wrong to do something to the anterior leaflet, but I would say that when you get comfortable getting your myectomy trough, as you said, Ben, down, the caudal extension of the trough down opposite the papillary muscles, the need to do something to the anterior leaflet becomes less important at that point, as opposed to if you can't, then it becomes another thing in your armamentarium to consider doing. So, I think, that's it. We did look at it here in our series, and anterior leaflet length did not make a difference in terms of alleviating the gradient and abolishing the MR. But again, we just, he and I are so comfortable, going far down that the necessity to do something to it then becomes not critical. And even when, as Dr. Swistel said, even when the septums are not as thick as you'd like, you can still do septal resection further down. It's just the extent of septal resection is not as significant. It's when you have a 14 millimeter septum, it's obviously the degree of myectomy is going to be less than if you have a 22 millimeter septum. And it doesn't take much, to eliminate, the outflow tract gradient. You'd think, it's surprising that, the degree of septal resection is not that substantial. But again, it's going a little further into the ventricle, to be sure. I want to say, because I don't want the cardiologists and the patients to feel that we got three surgeons on the call here that are damning mavacamten. I will say I know a number of patients that feel a lot better on mavacamten. So I mean, there are patients that do feel better on that drug, and so time will tell. It's a lot. It's intense, and it's a lot of surveillance. But with that aside, I know a handful of patients, a couple of which are physicians that are on it, and there is no question that they feel better. So I don't want the audience to think that we have three surgeons here that don't think there's a role for mavacamten. I think that time will tell precisely what the role is. I was interested in mavacamten from the beginning because I thought maybe it has a role with patients that have a lot of diastolic dysfunction, because we don't have a magic drug for diastolic dysfunction. And if the drug turns out to be helpful for that, that would be a very good thing for the HCM population. Time will tell where this fits into the armamentarium, but it does help some patients symptomatically, for whatever
Yeah,
that's worth.
Yeah.
absolutely. I feel the same way. It's good to have some, material for patients to consume that is talking about the benefits of surgery, because we don't have the marketing budget, Joe, that Camzyos does, and showing our patients running in the field happy and obstruction free. So surgery, mavacamten, they're both, we see the upsides of all of these things. I wanted to say, so I mentioned provocative maneuvers, of course, knowing you two and your surgical techniques and your body of work, and knowing that we have one who plicates more leaflets and works on the anterior leaflet more than the other. So interestingly enough, as I learned it, Dr. Dearani, as you were saying from Hartzell Schaft's school of teaching, is you almost never have to do the anterior leaflet. And I found myself not doing it a lot, but I have dabbled more into especially secondary cord cutting. And it's, it's hard to tell how much that is to the benefit, but when you look for the abnormalities and the abundance of secondary cords, and you see the restriction of the anterior leaflet improve with the secondary cord cutting, I found myself sort of floating to the middle of both of your schools of thought, where I certainly go for the depth, and if it's a quite deep hypertrophy, I'm not opposed to flipping the heart over and going through the apex to get the rest of it. But occasionally, I found that some of these anterior leaflets have some pathology that I have been finding myself correcting more. And another thing I wanted to echo, we talked about how our patients feel better in the hospital. What people don't realize is that the vast majority of heart surgery takes a while to recover from and to reap the benefits of the correction that the surgeon has made to your heart. I had a cardiac rehab nurse come up to me and say, your patients, your septal myectomy patients, are the only ones that want to walk more in the hallway, and they want to do more than we're telling them to do, because it's the first time they've been able to do something like that. She goes, these are the only patients I've seen where they feel dramatically better with a 2-day-old sternotomy than they did when they came in the hospital. So it is really, gratifying. I just wanted to close with one thing. I mean, obviously we want to reduce the gradient as low as we can. We want to fix the structural problem. We have all these tools at our disposal in the operating room, TE after we come off, we provoke the heart, we give isopril, we pace at a crazy high rate, we let them get empty. We do all these things. And sometimes you walk away and you think, I really nailed that one. That gradient, it was gone. That guy's going to do great, or that woman's going to do great. And then lo and behold, they come back and they have a gradient on their follow-up echo. Maybe they're not symptomatic, but the numbers, as you pointed out, they're different under general anesthesia. Are there things you think, besides the things we discussed, that can help predict patients that are going to have a gradient? Because as you know, some of these patients are so perseverating on the number. And I have this one patient who wanted to go on mavacamten, despite feeling a lot better after surgery and the symptoms almost being gone, had a residual gradient that wasn't in the operating room and was so obsessed with getting the number down despite feeling better. So what are any pitfalls for a junior cardiac surgeon in this field to besides the things we mentioned, to predict who's going to have a gradient, or is this just an inevitable outcome of some of these operations?
So there's a few things. So first, we've all been there. But a couple things that I've observed. First, if they have SAM in the OR, that's a problem at the end of the operation. Okay, because the gradient will be worse when they're awake and they're not under anesthesia. So be very careful of SAM in the operating room when you're done. Chordal SAM, it maybe or maybe not. But if there's leaflet SAM, it's not. You didn't do the job. So if there's leaflet SAM, you got to go back and take more. So that's the first thing. The second thing is whether there's any turbulence in the ventricle on the echo. Because if you are suspicious of obstruction and there's turbulence, they're going to have a gradient. So laminar flow is really what you want to see. And if you measure with needles and you do your provocative maneuvers and the gradient is 10 millimeters of mercury or less, and the flow is laminar and there's no SAM, that's about the best reassurance that you can get. And rarely would somebody come back with an important gradient if all of those three things were honored. Those would be the things that I would look at in the operating room. And is there contact between papillary muscles and the septum? And the reason why that is important to me, to your point, Ben, about the patient that comes back, is that beta blockers and calcium channel blockers, that is negative inotropes, they work well for dynamic outflow tract obstruction, which is at the base of the heart. But they don't work well for midventricular obstruction without SAM. It's like aortic stenosis in the middle of the ventricle. And so if the papillary muscles are hitting the septum and the gradient is in the middle of the ventricle, those patients don't respond that well to medical therapy, as opposed to the base of the heart, where it's dynamic outflow tract obstruction and negative inotropes work. And to your point about the echo, you can make the echo look like what you want it to look like. If that person drinks, a quart of water before they go into the echo lab, and they took their beta blocker an hour before they walked into the echo lab, it's going to look great. But if they've been NPO for 6 hours, they took their beta blocker 12 hours ago, and they walk into the echo lab, they're more likely to have a gradient. So you want to also get a handle on what the situation was with the patient when they had the echo that had the gradient, because depending upon, where the obstruction is and whether they're dehydrated or whether they're not, or whether they're adequately beta blocked or not, it will affect what the echo reading is. So I would not overreact to an isolated echo reading. I would, refine medical therapy, repeat an echo a month later, et cetera, and go from there.
I think, to reiterate what you said, Joe, the key to getting this surgical myectomy to be as successful as it possibly can be is to get the flow dynamics right, which requires a resection through the middle of the ventricle beyond the papillary muscles. And that alters the flow dynamics. And actually, if you get the flow dynamics right, it will help push the anterior leaflet posteriorly instead of pushing it anteriorly. So you can say what you will about manipulating the anterior leaflet of the mitral valve, or its chordal attachments, or its basal malpositioning. The key is the flow dynamics through the ventricular chamber, which requires the myectomy to extend far enough down. And I think that's the the single most important aspect of the surgical myectomy. Of course, I feel a little bit differently. I feel that if the anterior leaflet of the mitral valve and or its chordal attachments and or accessory papillary muscle structures are contributing to turbulence or some degree of alteration of the flow dynamics, then that should be addressed in order to get a good long-term result. And so you can say that maybe manipulating the mitral valve is my hedge towards a good result long-term, and I guess that's how I would put it. But we certainly have shown that in a 5-year follow-up study, we have had almost no residual gradients in our patients, whether they have mitral valve manipulation or not. But flow dynamics is the key to that success.
Yeah, I agree with that completely. Just to be clear, accessory papillary muscles, that's a structural problem with the mitral valve. So of course they need to be excised, they need to be shaved, they need to be trimmed. Any structural problems with the mitral valve, obviously we address that. I don't want somebody to leave here saying that we would not excise an accessory papillary muscle or excise or incise accessory cords that are tethering the valve. The time when we leave the mitral valve alone is when the only abnormality is just an elongated leaflet. That's when we rarely touch it. The other thing I was going to say is the PVC. The PVC in the OR is very telling, and particularly with needles. When you have the Brockenbrow sign, when you have a big gradient when you do a PVC, that's residual obstruction. You gotta go back and do more. So the PVC is really a very telling finding as well in the operating room with needles in the heart. If you do not have a gradient with a PVC, that's very reassuring. And so keep that in mind too.
Well, thank you so much. It's a total honor and privilege to be able to interview the both of you about this subspecialty that we find ourselves in. I appreciate both of your contributions to the field and for your mentorship. It's a craft that we need to preserve. So the people that are in this field, it's nice to be able to have such open collaboration and discussion, because really, it's something we need to all share the knowledge we have and make everyone and make the field progress, especially when we have things like mavacamten to compete with sometimes. So I want to thank you both so much for doing this, and that's all I have.
Thank you, Ben. Thank you, Dan.
Thank you.
Yeah.
That was Dr. Benjamin Van Boxtel, Dr. Daniel Swistel, and Dr. Joseph Dearani. To learn more about the HCM Society, please visit hcmsociety.org. This episode was edited and produced by Earfluence. Thanks for listening, and we'll talk to you soon on In the Thick of It.